Dr. G. Han-won. He is a professor at the University of Harvard and with many journal publications for many advances in infusion chemotherapy. Today, he will present topic endovascular treatment of maturation failure in hemodialysis access. Sorry, I speak Vietnamese by my audience. Kính thưa quý thầy, quý đồng nghiệp, phiên thứ hai đó là cái hội điện quang can thiệp Việt Nam sẽ gặp hội điện quang can thiệp Á Châu Thái Bình Dương. Và cái đề tài đầu tiên do bác sĩ G. Han-won sẽ trình bày về cái đề tài can thiệp nội mạch điều trị cầu nối lọc máu không trưởng thành. And now we honored to introduce Dr. G. Han-won. Please present your topic.
I am Dr. Jae Han-won from Korea. I work for a university hospital in Suwon. Today, my talk is endovascular treatment of maturation failure in hemodialysis access. Failing to mature arteriovenous fistula, maturation failure defined as a surgically treated AVF that failed to properly grow to become usable for the purpose of hemodialysis in 8 to 12 weeks after its creation. The incidence is a little bit high, so 23 to 46%. Etiology of maturation failure are poor inflow, poor outflow, and too much outflow. It means many collateral competing veins. Causes of maturation failure are classified as poor native vessel and post-surgical derangement. Poor native vessels are related to suboptimal artery, less than 1.5 to 2 millimeter, or a vein 2 to 2.5 millimeter in diameter, and extensive arterial atherosclerosis and pre-existing venous stenosis or even venous occlusion, and presence of accessory veins. Post-surgical derangement are narrow arterial anastomosis, juxta-arterial anastomosis, stenosis, and venous stricture formation. Classic radiological finding of AV fistula maturation failure is tight anastomotic stenosis like this. The stenotic area is histologically aggressive neointimal hyperplasia. This is the frequency of specific derangement. Most frequent stenotic area is juxta-anastomotic stenosis. Venous stenosis and arterial anastomosis stenosis are also frequent stenotic area. This is our data of endovascular treatment of maturation failure. Our data shows similar result. Juxta-anastomotic vein stenosis is the most frequent area, and arterial anastomosis and venous outflow. The percent collateral veins after angioplasty was 13.5%. Now I'll show you example case. This 47-year-old man had a left radiocephalic fistula. The fistula was failed to mature due to juxtaanastomotic venous stenosis. Initial fistulography also showed a thin collateral flow. After successful angioplasty using conventional balloon, sufficient venous blood flow was noted and the collateral drainage was disappeared. This is an example of arterial stenosis. Radiocephalic AV fistula was filled with backflow, artery and palmar and distal radial artery. This backflow filled AV fistula, but the flow is very small. Weak thrill was palpated. We select radial artery with 4 French Berenstein catheter. You can see the very small diameter radial artery and occlusion of distal radial artery. We dilated the radial artery with 4 mm balloon and arteriovenous anastomosis with 5 mm balloon. Completion fistulography shows very good result. There are some controversy in treatment of accessory veins. Thomel mentioned that lack of maturation was caused by underlying venous stenosis in 100%, and they advocated angioplasty in all immature fistula. In contrast, Fiaja et al. Argued that lack of maturation is commonly caused by accessory veins. In this picture, you can see multiple accessory veins. This is radial artery and cephalic vein. Embolization or ligation of accessory veins would augment flow within the intended outflow vein and thereby enable maturation. In this patient, before balloon dilatation, there are many the collateral veins. After balloon angioplasty, you can see a widely patent AV fistula and the collateral veins are disappeared after angioplasty. Next case, the patient has radiocephalic fistula. Maturation failure due to juxtaanastomotic stenosis. In spite of successful angioplasty of juxtaanastomotic stenosis, large consecutive veins were persistently seen and thrill was weak. We performed the core embolization of the lateral with filling of consecutive vein and this collateral vein. After that, final histography shows very good flow and strong thrill was palpated in this patient. According to this literature, they suggest diameter criteria for accessory vein obliteration. 6% or greater diameter of the main AV fistula and 50% diameter of AV fistula with at least one more accessory vein over 40% in diameter. 50% in diameter and divides into branch of same size. Accessory vein likely to interfere with cannulation on physical examination. These are diametric criteria for treatment of accessory vein. Accessory veins, live or not, the role of accessory vein obliteration remains unclear still. Accessory vein as a sole cause of non-maturation is infrequent. If the accessory vein still had significant downstream flow even after the stenosis was treated, it should be obliterated either by surgical ligation or by coembolization. Intervention is effective when AV fistula had side branches without coexisting stenosis, and a diameter decrease immediately further along in the flow path from the side branch. But ligation is cheaper than embolization. So now we don't do embolization. If necessary, the surgeon do surgical ligation of accessory veins. Both embolization and surgical ligation demonstrated similar result of maturation and long-term functionality. This is our result of endovascular treatment for maturation failure. Technical success was 94%. Clinical success was 86%. Complication rate is 6.3%. Two major complications are vein rupture, 1.4%, 7 minor complications, about 5%, or are puncture site hematoma. According to the literature, complication rates are similar. One article said rupture of weak venous wall is common, about 50% of patients, the majority of which can be managed with just prolonged balloon inflation, balloon tamponade. In another article, local hematoma formation occurred in about 15% of the patients. In most cases, the hematoma was self-limiting and was contained simply with application of local pressure. This is our result. Primary patency rate at 6, 12, and 24 months was 84%, 70%, and 6%. Secondary patient rate is 97% at 6 months, 82% at 12 months, 82% at 24 months. Our result of endovascular treatment is similar with other reviewed data. Clinical success is very similar. Primary patency at 12 months and secondary patency at 12 months are better than reviewed data. Major complication rate is similar. By multivariate analysis using Cox proportional hazard model, patient age over 65-year-old and over 90% stenosis were the independent predictor for the primary patency rate. Stenosis over 90% was the only independent predictor for both the primary and secondary patency rate. This is transradial artery approach from my Korean colleagues. Transvenous success was not feasible because the draining vein was small. They inserted small sheaths, 4 French sheaths, into distal radial artery. Single sheath is sufficient to treat downstream, even multiple or completely occluded lesion. You can see multiple stenosis here and here. After balloon angioplasty, they use cutting balloon. You can see the improved multifocal stenosis. But this transradial approach has disadvantage. Small diameter of the radial artery limits the passage of the large balloon or the thrombectomy device for declotting of a large thrombus, and more complication rate than transvenous approach. Maturation failure has difficulty in accessing immature vein because they are thin and fragile. Hematoma formation has been reported to occur in as many as 50% of procedure in which immature vein has been accessed. So we prefer transjugular access. Advantages of transjugular access are avoid the difficulties in cannulating immature veins, avoid the risk of hematoma formation after sheath removal, can treat multiple lesions through a single access. Operator's hand can be kept outside the direct field of fluoroscopy. This is an example. We inserted 6 French sheaths into the internal jugular vein. We advanced 4 French catheter to radial artery and performed fistulography. You can see juxtaanastomotic stenosis after balloon angioplasty from the internal jugular vein. You can see the improved stenosis. This is another example. We approach through the internal jugular vein, transjugular access. We failed to find cephalic vein orifice. So we used 23 gauge scalp needle to get venography. This is 23 gauge scalp needle. This is less traumatic and easy to hemostasis. We puncture the forearm cephalic vein, and venography shows small cephalic vein, but basilar vein is widely patent. So we approach it to the basilar vein. So fistulography shows this artery and juxtaanastomotic stenosis. This is the cephalic vein. We performed balloon angioplasty with a 6 mm balloon. After the balloon angioplasty, no residual collateral vein and widely patent the fistula. Series palpate after the angioplasty. We report our result in JVIR. In 90 patients, mean total procedure time is 36 minutes. Venography using a 23 gauge scalp needle was performed in 31%. The mean time to venography was about 12 minutes. This is another example of transjugular approach for brachiocephalic AV fistula. In this patient, we use scalp needle. We get the venography. Venography shows the juxtaanastomotic stenosis here. Under the road map image, we can find cephalic arch. So we negotiate the cephalic arch and the cephalic vein, and then we get the fistulography. You can see juxtanastomotic stenosis here. We performed balloon angioplasty. After that, completion fistulography shows very good result from anastomosis to cephalic arch. This is the result of transjugular access. Transjugular access was successful in 92%, and 7 patients required additional standard or transarterial access. Technical and clinical success rate was 98.9% and 90.5% respectively. As a minor complication, venous rupture occurred during balloon inflation in 9 patients, 10%, and it was managed by balloon tamponade. This is an example of additional arterial access. Venography using a scalp needle demonstrated an extensive network of collateral outflow vein associated with the complete obliteration of the main outflow vein. There are too much collaterals. The guide wire could not be negotiated towards the anastomosis, so the brachial artery was accessed, and 4-French sheath was placed. Load beam image acquired from the arterial side of the AV fistula demonstrated anastomosis and juxtanastomotic segment of outflow vein. The obliteration of cephalic vein. After passing the guide wire from the brachial access into the obliterated outflow vein, a through and through access was achieved between the transjugular and transarterial access, and angioplasty of the outflow vein was performed using 6 mm balloon catheter. The completion, the fistulography shows good outflow. This is the case of bilateral approach from transbrachial and transjugular simultaneously. This is the result of transjugular access. Primary patency rate at 3, 6, and 12 months were 84%, 67%, and 48%. Secondary patency rate at 6 and 18 months were 98% and 95%. Very good result. This patient has maturation failure of brachiocephalic vein fistula. Venography shows apocephalic vein was obliterated. This is small collateral vein. The fistula flow is drained into the basilic vein through the multiple 2 collateral veins. We select this collateral vein and dilate with 5 mm balloon. After that, fistula flow drain into the basilic vein through the dilated collateral vein. Still was palpate. Hemodialysis access was successful. This segment is enough for cannulation of hemodialysis. In my conclusion, Endovascular treatment enhances fistular maturation. Once usable, DJB fistulas have good long-term assisted patency rate. Transjugular approach for the PTA of immature AV fistula is effective and safe. Using this technique, vascular damage of fistulous tract and hematoma formation at the access site can be avoided. Thank you for your attention.